Beloved NHS, many of us know it was born in 1948, but very few see that it could have been killed in 2021. This is because in 2021 a bill was introduced, is being processed now through Parliament, and unless sufficient protest is made, will be fully enacted in 2022. This is a short presentation describing that bill and its effects on the NHS and social services. It's quite likely that you are familiar with the history of the NHS and social care and the way in which privatisation has been introduced into both, but it's worthwhile quickly recapping via a timeline. In 1948, the whole nation was informed of how it would work. All will register with a GP who will provide primary care, and if necessary the GP could refer on to hospital for secondary care. We all pay taxes which are used to build the healthcare fund from which central government paid GP and the hospital for provided services, and of course other services such as ambulances. Payments are made after services are given. Hospital services paid on a system of national tariffs. Every medical procedure allocated a price, every hospital paid the same tariff. GPs, however, paid on contract. They subcontract to the NHS because in 1948, right up to the current day, that's now, the majority of GPs are private partnerships. During the 1950s, 60s and 70s, the NHS continued to be developed and a social care system developed in parallel to assist patients if needed after their treatment. A patient's needs were assessed prior to discharge from hospital so that family and local authority could plan and arrange suitable services. Social care services, also funded by our taxes, but local rather than central, what we currently call council tax, although there is also an element from central government. Social care services help members of the community who need help with day-to-day living for whatever reason, not just following medical treatment. At the end of the 1980s, the march to privatisation began by the government of the day splitting the NHS into two, purchasers and providers. This was done by creating an absolutely totally false business market. This basic structure of purchasers and providers has continued and been built on ever since. All governments of all colours right up to the present day have made changes to both NHS and social care that move them to a model based on that used in the USA, the Kaiser Permanente system of insurance-based healthcare. In 2012 saw the first of the bills that changed the NHS wholesale, the structure and the way of working. This moved the NHS from being providers of care to purchasers of care via a tendering procedure. Services were purchased from many types of providers, private companies in particular. Clinical commissioning groups were set up to purchase and plan healthcare. They were advised by support groups, for example, McKinley and Optum, Both are from the US and adherents to Permanente. CCGs are GPs. The 2012 Act gave overwhelming power over our healthcare into GPs' hands. The 2021-2022 bill will take the 2012 Health and Social Care Act as its basis and build on it to change our healthcare provision beyond all recognition. So, what's in the 2021 bill to be enacted in 2022? Its main points: another restructure, of course, and an astonishing clause that says secondary care, you may remember, is that given in hospitals? A similar clause about social care, and a worrying amount of deregulation. The NHS will be restructured in this way. Integrated care boards will be established. They are regional, and for their region will prioritise, plan and deliver care within a budget allocated on a strict annual basis. They will be directly accountable for the NHS spend in their area. The original intention was that providers from the private sector could sit on ICBs. This hopefully will be removed by an amendment already laid down. About the restructuring. The 2012 Act introduced clinical commissioning groups and integrated care partnerships. CCGs are no more, being replaced by the ICBs. The care boards are a level above the integrated care partnerships, the ICPs being subcommittees of the integrated care boards. Providers from the private sector can sit on ICPs. Only one local authority representative, however, will be able to sit on both ICB and ICP, even though several local authorities will be in the ICB area of responsibility. The care partnerships will be responsible for identifying all healthcare needs, that's different types of healthcare, for the area, and producing a report which will be fed into the ICB. However, they are not obliged to follow this report, because the Act states, quote, "The ICBs must have regard to, but not necessarily adhere to, the assessment of needs as identified by the ICPs." Services will undoubtedly be reduced. The most worrying is secondary care, you may remember, is care that is provided by or in hospitals. The mandatory level of care provision instead of hospital care is not fully described in the Act, but a similar description is used in the Act as that used in the US HMO system of, quote, "basic and supplemental health services." Similarly, it's not clear who the ICB is responsible for. Instead, the responsibility is for a group of people for whom the ICB has a quote core responsibility. Neither are fully defined in the Act. This leaves you with so many questions, I'm sure. For example, where will patients needing A&E care go if their ICB doesn't provide secondary care? Will certain people within the group be denied care if their needs fall outside the core responsibility? What if you're taken ill on holiday? Can you be treated outside your normal ICB? None of these questions are answered. Similarly, social care services will be reduced. Because only one local authority representative will be allowed to sit on either the ICB or the ICP, so the local authority influence on the board will be minimal. Some service reductions are already recognised just by looking quickly at the bill, because when a patient has actually received hospital treatment, they could be sent home without care or even dumped. Because the level of needs will not be assessed until after discharge from the hospital. What is included after a period in hospital is not fully explained, but what is removed is the assessment. The words are twisted on this, and this is now called discharge to assess. This will undoubtedly put pressure on social care providers and family. The 2012 Health and Social Care Act was criticised for introducing the purchase of care services, but at least the tendering was subject to financial scrutiny and had to be properly advertised. Both will be removed by this bill. So care services, primary, secondary and social, will be commissioned by the ICB from any type of provider. That's NHS trusts, local authorities, private providers, volunteers, charities, without any financial regulation. The ICB has an annual budget taken from the national healthcare budget. But instead of payments being made to providers being the same nationwide, each ICB will be able to negotiate the tariffs for provided services. Service providers sitting on either ICB or ICPs will surely be able to influence this negotiation, a clear conflict of interest. The ICB is now responsible for all healthcare in their region. However, the flow of payments to primary care and social care is not actually defined. Will the way in which the needs for the region, as specified by the ICB, mean that Peter will be robbed to pay Paul? New staff contracts will be introduced by the Act. These contracts require staff to move between services. Also, it's no longer mandatory to adhere to the national pay scales and grades as set up in previous national agreements, leading to care being delivered by lesser or even unqualified staff. Many of these changes have already been made. CCGs have been disbanded, ICPs have been set up, and positions advertised for ICB members. However, they will not be fully implemented until this law is passed. The impact will be postcode lottery, healthcare policy no longer national. In future, each area's healthcare priorities will be set by the Integrated Care Board. Rationing. The need to adhere to a strict annual budget and the fear that that budget will run out will mean that services are rationed. This will push more and more people to use the private sector to avoid waiting times. Cronyism. Such an inflammatory use of words, but we know what happened during the COVID pandemic. This bill removes the financial regulation on the award of healthcare services. The fear is that the private sector will negotiate rates as a loss leader. NHS trust hospitals will not be able to match those rates and so lose contracts which will be almost impossible to reinstate. Unmet social care needs. The discharge to assess system being introduced will place a great deal of stress on family members and on social care planners, as the patient's needs will not be known. At its worst, this can result in patient dumping. Private sector influence over tariffs and planning. Hopefully the bill will be amended to prevent private sector from sitting on the actual boards, but they will still be on the integrated care partnerships and so be able to pressurise ICBs, particularly by offering lower prices for services. At this stage of the bill's journey, the best and easiest process to make is via an email to your MP. She or he may already be opposed to this bill. If so, ask them to be vocal with MPs who are in favour of the bill about your view on what will be the outcome if the bill is passed. And also point out that this bill does nothing to cure the current problems with our health services, which have been cruelly exposed by the COVID-19 pandemic. This bill does not help at all to rebuild and restore services after years of cuts and closures. It doesn't prevent corporate takeovers of GP services. It doesn't address the failings of track and trace. And it does not address the broken social care system with which health services are supposed to be integrated. Operos Health is a subsidiary of Centene, which is a large US care provider. Thanks for listening. I've only given an overview of the problems with the 2021-2022 Health and Care Bill. Please refer to the experts. Here's some suggestions. The first link shows how all governments of all flavours have believed in the Kaiser Permanente that is the USA system of insurance-based healthcare. You may wonder why I've included the second link, which is actually a talk about the 2012 Act, not the new 2021 Act. But the 2012 Health and Social Care Act is the founding father of the new one, and this talk shows how it prepares the NHS for privatisation. There's much information on the internet that you can find. My own personal favourites are the work of Professor Alison Pollock and also the CHPI. The CHPI put out many reports. I must admit they do tend to be a long read, but they're very clear and they contain lots of information and lots of financial information, so it's a good source for figures and the usage of money and our healthcare budgets and so on. So thanks again for listening. Please do all you can to combat the introduction of this bill. We could end up with little or no healthcare if it goes through without much amendment. Thanks again. Bye.